Welcome back to Mostly True Psychiatry with Dr. Mellon. Today is going to be the beginning of a series on schizophrenia. Probably this video and the next several are going to be just on the diagnosis of schizophrenia, and then we'll get into the treatment. So first and foremost, schizophrenia is a syndrome. It's not a specific disease. It's probably more in tune of like saying someone has dementia or epilepsy versus it being a specific like gene or anything involved. People have been chasing this for a long time on what causes schizophrenia. I'm trying to look for specific genes, looking for autoimmune disorders, infections, like viral infections, stuff like that. Everything's come up negative. One of the new theories du jour is probably that there's genes involving like promoter regions, so there are genes that affect other genes, and when one of those gets messed up, it can cause it's not just it's like a promoter, so it's like how many copies are made as well, and that kind of stuff, controlling if too many or too few are made, and the timing. And there's some evidence right now that maybe schizophrenia just has to do with those genes being messed up that affect 100 other genes, and a lot of those genes associated with schizophrenia. So it could just be that, all these weird like architecture, cytoskeleton genes and stuff that have been associated with schizophrenia. It's really just that they're getting abnormally promoted at the right time frames and sex specific that maps with schizophrenia on the onset between men and women. It would make sense why you have like 100 genes that way that have been associated with schizophrenia, even though a lot of them really don't seem like they'd make any sense, but it could be they're all just being affected at the same time, and some combination of them tend to cause the whole global brain dysfunction that we call schizophrenia. So the DSM diagnosis, criteria A is the big one. We're probably going to do a video on each of these topics. So you're supposed to have at least 2 of these symptoms, at least 1 month continuous, most of that month, realistically 6 months before you can even consider it schizophrenia. It should be a permanent thing once it starts. It's not an on-off. So you're looking for negative symptoms of schizophrenia, so it's absence or reduction of normal function, poverty of speech, flat affect, asocial. So these are just things where like a lot of people with schizophrenia, this is real common. They don't show a lot of facial expressions, so it looks fake when they're smiling and stuff. It doesn't really match what they're saying or their environment. And they'll have, it looks like we say that they're not interested in things, like that's what he's calling anhedonia, but I kind of look at it really like they don't get bored, like they're just kind of hanging out doing the thing, and when you ask them, are you bored, are you trying to do stuff, no, they're fine with what they're doing. So those are the negative symptoms with schizophrenia. Hallucination and delusions kind of go together. So hallucinations are perceptual experiences without the external stimuli, and the auditory is considered separate of their own thoughts. And commonly, when people are hearing stuff, constantly chatter, it leads them to have delusions because they're hearing stuff. A few more things about hallucinations in general, just is that it's the most common thing to happen as far as is auditory for hallucinations. If you just have visual hallucinations, you're really thinking drugs or organic brain dysfunction, something like Parkinson's disease and stuff, which you'd have an age associated with it. But if you have a lot of visuals, it might not be schizophrenia at that point, or show you they're malingering or something else. Auditory hallucinations are there commonly. They used to ask about some of the other stuff a lot more, and they showed up more, so they probably still occur at the same frequency. We just don't ask about them anymore. For delusions, these are firmly held beliefs that cannot be changed despite evidence to the contrary, and it's out of the social norm. And that was plugged in because this used to be a racist thing where if you were black or other minorities, you magically had more schizophrenia than the white folks in America. So they did that, trying to knock that racist chunk out. We'll talk about some of these more specifically later. And then their speech or their behavior is very disorganized. So when its behavior is disorganized, that goes from being not, it's like a term of art in the DSM. It's almost like you know it when you see it. It has no meaning. They put like, may be noted in any form of goal-directed behavior. Like, what the heck? What is that supposed to mean? So it probably just means, they're not it probably means they're having problems. They're ADLs. They're not able to do the normal things they're supposed to do during the day. They're doing mannerisms, stereotype, either repeating stuff. They're just standing there, not doing anything. I mean, that's the other way. And then catatonia, we'll talk about it later, because that's a specifier in the DSM. It happens with bipolar disorder, depression, that kind of thing as well. It's a description of a severe type of behavioral change that takes its own treatment and is dangerous. So then there's disorganized speech. Again, this is I know it when I see it in psychiatry a little bit. There are no official formal thought disorders, which is a formal thought disorder is supposed to be the same thing as disorganized speech, but then they talk about the kind of common list. So these are the things you always learn about starting in medical school, like circumstantiality and clang association, derailment, word salad, these kind of things. Like word salad just mean like how disorganized they are at that point. Neologisms, these things. So if they're really, I mean, people with schizophrenia, as you interact with them more, it becomes real obvious, like they're the way that they tend to behave or act, or kind of the realms of norms for it. So you need at least 2 of these. You have to have a clear sensorium at the time. It can't be that you're on drugs or an infection or something going on, because then you don't know what's going on. So disturbed functioning since it started. So it starts, keeps going, doesn't get markedly better. It has to be at least 6 months. If it's less than 6 months, it's schizophreniform. If it's less than a month, it's an acute psychotic disorder. And then you've got to rule out that they're not having a mood disorder with it. So if they have depression or mania, it's got to be present only a minority of the overall presentation. So schizophreniform gets slapped on everything in the U.S. whenever they're, especially like long-term inpatient or state like government systems and stuff. But if they're euthymic, most of the time it's just schizophrenia. If it's a persistent and significant portion of the process, then you can call it schizophrenia. But a lot of times it'll be like somebody, they tried to commit suicide. Well, obviously that's major depression. It's like, no, they're untreated with severe, like ongoing auditory hallucinations with delusions that were all persecutory and terrible things were going to happen and they can't sleep and everything's awful. And like, it's just kind of like if you just kept torturing somebody and like, oh, look, they tried to commit suicide eventually. It's like, well, yeah, they're being tortured. So it doesn't mean you're depressed. It means that you're just acutely psychotic and not getting help. Can't be due to another medical condition or drug. So if you're on LSD and meth, it doesn't count. And then here's a fun one. So can't have autism or communication disorder because, fun fact, historically, autism was confused with schizophrenia. So, yeah. There's test scales, questionnaire stuff on schizophrenia. I've never seen a psychiatrist in my entire life use one. So academic, I don't know. It's for psychologists or something. I don't know. Research. The specifiers in schizophrenia under 13 is considered childhood onset. 13 to 18, that range, is considered early onset. And just like everything, earlier is worse when it comes to psychiatric conditions. There's a Likert scale thing. It's like 0 to 4, 0 being not present to 4, present and severe. I've never seen anybody use that in my entire life, but if it's realistically, you can, if you want to start early in your career and just start being more specific and exact about how you do a diagnosis and you put all the pieces to it and that helps you decide if things are getting better or worse, that's very reasonable. Just because the older psychiatrists, like in my generation and ahead, are lazy doesn't mean you need to build good habits early. Catatonia needs to be specified because that gets its own special treatment and you're pumping a full Ativan or whatever you're doing. So put that on there if it's present. And then there's all these specifiers. Again, I've never seen anybody really do it. But the idea is it's at least a year into the process, and then you're doing these. So these are specifiers, whether it's a first episode, multiple episode, or continuous. Continuous means just can't control it. It's really severe. And then whether it's first episode or multi-episode, you're saying it's either currently active, or you're in a partial remission or a full remission for that 2 months, or that that's it, or unspecified. But no, I don't feel bad if you don't put any of these. People usually just write schizophrenia and move on. But I think that's kind of all you need to know for this video. So like I said, we're going to go over kind of specifics on the hallucinations, the delusions, what are things to look for from malingering, from Resnick, and that kind of stuff. If you don't know Philip J. Resnick, you will by the end of your psychiatry training. All right, so that's been Mostly True Psychiatry with Dr. Mellon. Hopefully this was helpful, and I'm going to try to put out a couple more videos before I see the next patient. Cheers.